All right, guys, so Chapter 12, disorders of hemostasis. So the big things with the clotting, the hemostasis is truly clotting, and so the biggest goal with that is obviously to stop bleeding. And for the most part, we can do that at the very microscopic level of the blood vessels themselves, or it can be involved with large injuries, large trauma, and usually what we want is to maintain the fluidity of the blood, as well as letting it get everywhere it needs to be, but then as well as keeping even micro tears at bay with the blood clotting. So when we have abnormal hemostasis, we start to get into either inappropriate clotting, like we talked about DVTs and strokes and pulmonary embolisms, or we can have insufficient clotting where someone does not clot enough and they can bleed out and have aneurysms and those types of things. So let's talk about platelets. The fancy word's thrombocytes for these guys, usually 8 to 9 days in circulation. Storage in the spleen. These guys come from what we call the megakaryocytes in the bone marrow. And much like we had when we had red blood cells with the erythropoietin, we have thrombopoietin, which is a hormone that causes the production from megakaryocytes of platelets. And so most of this is done in the liver and kidneys, as well as the bone marrow. So remember the structure of the platelet, the big things that are on here is that we have these adhesion molecules that allow the coagulation. And with that, we also need calcium. So that's going to be a big cation that we're going to need when we have clotting. And calcium, and you guys remember, storage of calcium is in the bone, and we have osteoclastic activity and osteoblastic activity and all that great stuff. And remember before we talked about a type of cancer that causes increase, multiple myeloma causes an increase of osteoclastic activity. So there is a potentiation for an increase in calcium into the blood supply. So we're going to have this is going to be a big part of it. So I'll go to the following or two about platelets. So platelets, we want to see thrombopoietin is going to be the big hormone for that. So plasma protein. So with this, we have this cascade of events. And plasma proteins are inactive, very inactive coagulation factors. They're made in the liver, and they basically wander around, okay? So we have this factor, von Willebrand factor, made by the megakaryocytes and endothelium that's going to be involved in platelet adhesion. So write that down, please. The von Willebrand factor is for platelet adhesion. And so we have a few things that are going to happen. We're going to have a constriction of blood vessels that's going to be very localized. We have release of the von Willebrand factor, and then we have this activation of platelets using adenosine diphosphate as well as thromboxane A2. And remember, thromboxane A2 causes vasoconstriction, so it causes the blood vessels to get smaller, causes the hallway to get smaller. And this is going to also attract more platelets to come to that specific area. And we also have a flooding of calcium in the area, which also allows the coagulation of the platelets to cause the clot to begin with. So this is what it kind of looks like over time. With the intrinsic factor, we have intrinsic system, we have blood vessel injury. And we start to go through all these little factors and activation of these factors. Don't get too caught up into them, but know that the intrinsic and the extrinsic system comes down into using calcium to activate prothrombin into thrombin. Thrombin activates fibrinogen into fibrin, and then we start to get this polymer buildup of the clotting. So don't get too caught up in these different factors, factor 12, factor 10, factor 11, factor 9, all these great things. Really just remember the role of calcium and calcium's involvement with prothrombin to thrombin, which is then going to activate fibrinogen to fibrin, and then we can start to make our clot. So a man has a stroke, the doctor gives him TPA. So remember we talked about TPA because with this tissue type plasminogen activator, this has a very high affinity, so it's going to stay very localized, very local with this. We're not going to use something that causes thinning of the blood throughout the entire body. It's going to thin the blood in a very small area. So that's the big thing with stroke. So hypercoagulability. We have an increase in platelet function. We have increase in number, which is going to cause a lot of blood flow disturbances and endothelial damage and platelet aggregation. So here we go with this increased platelet function. You can start to see where it starts to kind of snowball down the hill. And then if we have accelerated coagulation activity, so now we have either an increase in the procoagulation factors or a decrease in the anticoagulation factors, we're going to get hypercoagulability. So highlight these two, kind of be a little bit comfortable with them and how they work functionally, because that's going to be a big part. When we get into this hypercoagulability, this is going to make us prone to what we call deep vein thrombosis, or DVT. Very common in the lower extremities, very common in a lot of different cardiovascular situations. We can have fluid build up in the veins of the lower extremities, and when that clot, basically, whenever we have blood that's stasis, whenever blood hangs out, it's going to clot. Whenever it's not moving, it's going to clot. And if that clot breaks off the side of the internal lining of a blood vessel, that's what we call an embolism. And that clot is moving through the blood supply, and it's going to get stuck the next time the blood vessels get thin, and that's going to be in the lungs. So please highlight that DVT causes pulmonary embolism, or emboli, and this is going to be in the lungs. So, platelet disorder. So we can have a situation where we have thrombocytopenia, which is a decrease in platelet production, or we have an increase in their destruction. Nonetheless, we have a lot of a decrease in the clotting, where we have a lot of bleeding out. And with this, we talked about this, where we have purpura, which is a fancy word for bruising, and we also have petechiae, which are these very small hemorrhages. And immune thrombocytopenic purpura is very common in kids. We call it ITP, immune thrombocytopenic purpura. And that is bruising in kids, which is really hard to identify because you think kids just being kids, and unfortunately it is an actual immune response that's destroying the platelets in their blood supply. So, on lupus, so we know that lupus is an autoimmune, and she develops breast cancer. One of the big things with this is drug-induced thrombocytopenia. Drug-induced thrombocytopenia is going to be the big role with this. So, the COX system. We have COX-1, which is a cyclooxygenase, and we call that prostaglandin synthase. So COX-1 is prostaglandin synthase. It produces prostaglandins. And prostaglandins, as we talked about in class, certainly with the activation of arachidonic acid, it's going to be very pro-inflammatory. We also have COX-2, which is an enzyme that really promotes inflammation and pain. So, when we're looking at the inflammatory process, we have a COX-1 and COX-2, which start to move things along. And so the COX-1 catalyzes production of thromboxane A2, which we just talked about, and then COX-2, the prostacyclin, which is really going to promote inflammation as well as pain. So we talked about amino acids that are going to be, I'm sorry, not amino acids, but arachidonic acid, which is going to be a big part of this. Remember, we have omegas 6 and 9, which actually potentiate arachidonic acid. So that is the entire inflammatory response involving arachidonic acid. But how COX-1 and COX-2 gets activated to potentiate that cascade, but then also what we can do is as far as decreasing that immune system. So, or that immune cascade. So, von Willebrand disease on the platelet, so it's going to decrease platelet adhesion. Remember that the von Willebrand factor is involved with platelet adhesion. So, a DIC, a disseminated intravascular coagulation. So, really what we're starting to hear is that we have this thrombin, plasminogen, fibrin cascade that we were looking at earlier, and we can have either endothelial injury or actual full tissue injury that starts to activate the thrombin and then the plasminogen into plasmin and into the fibrin, and causing that clot to begin. And so this is one of the things that can start to happen, is that when we activate this, that we can actually promote, certainly with this, having the platelet consumption and the thrombocytopenia. And if we have this decrease in platelets, then we're going to have the bleeding. We're not going to be able to clot well. And the same thing is, if we have this promotion, we're going to have the lysis of the fibrin, and it's going to be degraded into causing more and more of the bleeding itself. So, question, platelet disorder, bleeding disorder. So absolutely true, because the platelet's job is to clot. And anytime we have a platelet disorder, we're going to be concerned with either too much clotting or not enough clotting. And so those are the things we want to control. So again, very skimming over the top. There's not a whole lot I want to get stuck onto with this. I just want to have some basic definitions down. So I know we talked about this in the in the sauna last week, but hopefully you guys can see just very, very skimming the top on this.